Good evening, everybody, and welcome to this evening's ASGBI Emergency Surgery webinar. And this evening's title is that of Troublesome Testicles. I know there's a sweepstake out there on how many slightly off-color remarks I'll make, and I'm going to try my absolute best to make none whatsoever. But I just want to reassure you, this isn't a feminist rant against the surgical patriarchy, but rather a webinar on the topic of torsion in both adult and pediatric patients. I'm delighted to say we've got a great panel comprising of urologists, pediatric urologists and general surgeons. So we should have a good and well-informed discussion. Next slide, please. So just a small plug for our association, because we're opening this evening's webinar to everybody because they think the topic's such an important one. But while you're here, the ASGBI is now in its 100th year, and in the words of L'Oreal, we are worth it. So please join us. As anybody who went to our recent EGS day will attest, we're fantastically modern, an organisation full of great educational opportunities for both trainers and trainees. We're here to support our surgical colleagues. Next slide, please. As with all our webinars, we had a Twitter poll in advance of this evening, and we put out the question, two questions. One, who should manage torsion in children? And two, who should manage torsion in adults? We had about 200 responses to both questions, and you'll see the question in children seems pretty clear-cut, that they feel it's a urology and pediatric surgery response, with very little opinions that general surgeons should deal with those cases, which is interesting. And second, the adult question. Now, obviously, we don't know who responded, but 90% of, and I'm thinking my own general surgical registrars, said that urology should manage torsion in adults. So that's a very definite response at the start of the evening. So let's see if we change that or not. There'll be the opportunity to vote live on this question. Again, you'll see a polling bar will appear on your screens at the end of all the talks. And prior to introducing our panel this evening, I want to say what an absolute pleasure it is to see the enthusiasm cross-specialty from general surgery, urology and pediatric surgery. And I hope if we can convey some of this harmony onto the shop floor for in use afterwards, we've done some good. So without further ado, I'd like to introduce our first speaker. And we are very honoured to have Professor Phil Cornford, who is chair of the Urology SAC. Over to you, Phil.
Thank you very much. For inviting me to come and talk about this, close to the heart of urologists. Okay, can I have the next slide, please? So I'm a Liverpool-based urologist from a big teaching hospital, and in Liverpool, all the testicular torsions in adults are done by urologists. So I should declare that before I start. We have a well-resourced on-call, and it wouldn't be unreasonable for us to do it. Next slide, please. So this is what the curriculum says. If we just press the next slide, then the absolutely clear that all urologists will be able to manage patients and treat testicular torsion. There is no doubt that that is central to what's going on in the new urology curriculum. Next slide. So why do we need to worry? So I'm here for two things. The first thing is that torsion is much more common in younger men, but it can occur at any age. It is a major cause of medical malpractice claims and continues to be a problem in the UK. And about 1/5 of patients present with intense abdominal pain, which may well be worse than the testicular pain. And that's probably more common in children than it is in adults. So they turn up with abdominal pain referred in with the general surgeons. And they don't necessarily get signposted to urology. Next slide. So the urology curriculum, this is from the recently approved new version of the urology curriculum, is absolutely clear. Investigation and management of acute scrotal swellings, including infection, abscess and torsion, level 4. Next slide. And when we look at emergency urology, orchidopexy and orchidectomy for testicular torsion, level 4, there was an expectation that people will be at that level before they end what is now the current new phase 2, which really means the end of ST5 for urology. So this is going to be a central part of what goes on. Next slide. So why do we end up in a debate about who's going to do torsion? Because if you work in a 18-man unit like Liverpool and you have a raft of urology trainees, then it's going to be done by us. It doesn't quite work like that across the country. There are currently 180 A&E departments reporting into the Royal College of Medicine audit on A&E and 132 trusts. And of urologists, according to the GERF report, only 41% of them always have on-call support from middle grade. Only 13% of them are completely freed up from elective work. And just over half of them are going to be covering multiple sites. So urology as a specialty is smaller and is spread across a lot of sites. And the other thing that GERF has encouraged and is also beginning to have an effect is the use of 5-day urology units and networking. So this means that in your local hospital, you might have a urologist there during the week, but on Friday night, they're going to pack up and they're going to go and be part of the on-call system in another hospital, sometimes quite a long time away. That's partially why there are still many opportunities for general surgery to do torsions. Thank you very much.
That's excellent. Thanks very much, Phil. I'm already getting several controversial messages about lack of support and consultant presence. And so I think it's going to be an interesting session for questions. I would now like to introduce one of my local colleagues, a really enthusiastic trainer, and I'm really pleased to let him know that he is in the lifetime post of Urology TPD and Heme, Mr. Dhaval Bodiwala.
Thanks very much, Jill. First of all, I'd like to thank Jill for inviting me to the Lion's Den of general surgical meeting to talk about acute testicular pain and management of torsion. I guess my only saving grace is this is a virtual meeting, so feel free to throw things at your own screen if I say anything controversial. Next slide, please. Now, slightly going on Phil's theme, I work in a big teaching hospital, but we cover 3 sites when on call. And one of those sites is 10 to 15 miles away. So management of torsion, to say it's complicated in our region is an understatement. I think Manoj will discuss a little bit about that later on. Next slide, please. I want to talk a little about our clinical presentation of torsion. Now, as has already been mentioned, and as Manoj will say, it's a vast majority in the pediatric population, but can occur in adults. You know the presentation, acute testicular pain, but beware of those patients who present with trauma to the testicle. And after we've ruled out tunica disruption, bear in mind that torsion could be a potential diagnosis. As far as examination is concerned, you know already a tender testicle and potential abnormal lie. Next slide, please. Now, as far as diagnostic tools are concerned, my personal opinion is radiological investigations are a complete waste of time. Not that they're not very sensitive, because they are, but actually this is a clinical diagnosis, and anything you do radiologically will really just waste time. So as far as I'm concerned and our trainees are concerned, the only real diagnostic tool we use is a urine dipstick to rule out infection. The only time we may use ultrasound scan potentially is if there's a delayed diagnosis and time is not as critical as it would have been otherwise. Next slide, please. Now, we've talked about differentials, infection, torted appendix of the testicle, and Manoj may mention this later on. You can see the blue dot sign. This is not obviously something you have in adults, it's something you have in children, but I'll be honest with you, it takes a very brave urologist or general surgeon not to take a patient to theatre when they've got acute testicular pain of short onset. Next slide, please. Now, as far as I'm concerned, I don't really mind who takes the patient to theatre and who assesses the patient. It just needs to be done quickly, because as the slide says, time is the enemy, and it has effects both to the patient and also to the surgeon, be it general surgeon or a urologist, because the longer you leave a testicle, the less chance it will survive, and there are risks for fertility with regards to the patient. And as far as the surgeon is concerned, as Fizz has already mentioned, there's a huge medico-legal implications related to either delayed or missed torsion. Next slide, please. Now, as far as time is concerned, as I mentioned, this is the key. And this is why it's so crucial that these patients are assessed and treated very, very quickly. Now, if you get to a testicle within 6 hours, vast majority of them will survive, but you start to increase the time from onset of symptoms. You see by 12 hours, nearly 40% will not be viable. Now, this is the onset of symptoms. So can I have the next slide, please? We did an audit in one of our local DGHs a couple of years ago, to be honest, where in Northampton, acute testicular pain is assessed and managed by general surgeons. And what we found was that from the time of registration to the time they went to theatre was on average about 3 hours, which is quite a long time. And this is from when they presented, not from when the pain started. And actually, if you look at studies, there is some debate about how long patients wait, and actually the younger patients tend to wait longer than the older ones. It can be anything up to 12 hours, so the clock is ticking even when they attend either the emergency department or the surgical admissions unit, whichever you have in your hospital. The interesting thing is actually the last line. As you can see, those patients who had a viable testicle went to theatre much, much quicker than those that did not. So this reiterates my point of time is of the essence here. Next slide, please. Now, one thing I wanted to do, or we wanted to do in this presentation is really talk to you about how we explore testicle. And this is slightly borne out by one of my colleagues who did a study in the Southwestern Severn region about 10 years ago, so where the curriculum may have been different then, looking at the management of acute testicular pain by general surgical and urological trainees. And what they found was actually when it comes to torsion, the management of acute testicular pain is exactly the same between the two trainees. The outcome is exactly the same, but what was different is a vast majority of general surgical trainees had never been trained by urologists how to explore a scrotum. What they also found was the vast majority of general surgical trainees would fix a testicle that was not torted. So I thought it'd be quite helpful for Susie, one of my trainees, to talk very briefly about how you would fix a testicle. Thanks, Susie.
Good evening, thank you for the opportunity. So it's not a difficult procedure. I'll go through it as simply as I can. Next slide, please. Under a general or a spinal anaesthetic, you want to make an incision down the midline raphe with a blade. A picture of a hands is here because it's really important you get your hands on there or an assistant to help stabilise the sort of the surgical environment. You then need to go through the dartos. So this is the vascular layer. So you'll need to do this with diathermy. Monopole is absolutely fine. And then you'll come to the tunica. So that's shown in the clips on this picture here in the Alice forceps. This can be divided with a blade usually or scissors, but you can use diathermy. And underneath that, you will then find the testicle, which is often surrounded by a small amount of fluid. And you can usually just pop that out through that gap. Next slide, please. You then will either find a perfectly pearlescent, clear, healthy looking testicle that the cord looks healthy, it's all pink, and that's a non-torted testicle. You might see some pustules on the cord, which might be a sign of infection, but if the testicle is nice, white and pearlescent, it's not torted. In that case, do not fix it and do not touch the other side. Put the testicle back in and then close, which I'll talk you through in a moment. Or you'll come across a testicle that comes out looking grey, or in this picture, this one's obviously quite dark and black. And we all know as surgeons what dead tissue looks like. You'll then get to the cord and it's really obvious when it's twisted. The first thing to do is untwist it, wrap it in warm gauze, put it down and leave it for 5 minutes. You'll then come across one of two situations when you look back. You'll either find a testicle that has pinkened up, looks healthy, it's blanching, and it's viable. And in that situation, you then want to fix that side. Now, to fix a testicle, you want to use a non-absorbable suture, such as a 3-O-proline. And you want ideally three sutures that go through in different planes, as shown in the two images here. You take one small pass through the testicle itself with the tunica over line the testicle, and then down into the scrotum. And just a bit of a tip, if you do all 3 sutures and then parachute the testicle down into the scrotum, it can save it being quite so fiddly. You'll come across a testicle that still looks dead. If you're not sure, you can make a small incision in the testicle, and if it doesn't bleed and it's still dark in colour, that's not viable. And in that situation, you want to remove the testicle. Place 2 heavy clamps on the cord, transect the cord, remove the testicle and the cord, and place 2 transfixion sutures with an absorbable suture. But you then need to fix the other side. So go through the dartos, fix the other side, and then close, as I'll go through in a moment. Now, with the torsions, you need a follow-up, usually 6 weeks for a clinical examination with a urologist. For the non-torted testicles, you do not want to follow them up. Next slide, please. Closing, important thing to remember is that the dartos is the hemostatic layer here. So a continuous suture, not difficult, with an absorbable suture, 2.0 or 3.0 vicryl, and then interrupted mattress or interrupted sutures on the skin with absorbable suture, and then a good scrotal support, because the chance here of a hematoma is something we worry about, so scrotal support afterwards. Thank you.
That's fantastic. Thanks very much for Susie. That's great. I'm reconsidering my jewellery choice after that pearlescent description. Never look at this necklace the same way again. So I would now like to introduce, we are extremely honoured this evening to have the president of the British Association of Pediatric Urologists. And I was warned in advance not to let him and Deval talk about cricket all evening, and they haven't managed that yet, but I think he snuck it into his slides. So Mr. Manoj Shenoy, thank you very much.
Thank you, Jill. Firstly, good evening all. And Jill, thanks a lot for inviting me to this webinar. Next slide, please. Next slide, please. So discuss this from a pediatric perspective. And when you look at the age spread, testicular torsion accounts for majority of the case of acute scrotum in those who are post-pubertal. In the prepubertal boys, torsion of the testicular appendage is more common. There are other conditions which I'll allude to in the subsequent slides. Next slide, please. When you look at torsion testes, the peak incidence is between 14 to 16 years. It is important to bear in mind that when you have undescended testes, they can get torted, and this is commonly seen in the infant age group. When you look at the pathology, if you look at neonatal torsions, the torsion is extravaginal. This means the cord twists outside the tunica vaginalis. In all other age groups, majority of the times it's intravaginal torsion, as you see in bell clapper testes. As Dhaval alluded to earlier, we routinely do not perform any imaging, as it's a time critical condition. If you suspect torsion, we would explore. Next slide, please. When you look at neonatal torsion, I suspect most of you in the adult field will not see this. The correct term is intrauterine or perinatal torsion. This means the torsion occurs just before a baby is born or soon after the baby is born. And the neonate presents with scrotal discoloration and an indurated testes. An astute midwife may pick this up. It's important to bear in mind that the prospects of testicular salvage is close to zero. What is more important though is to fix the contralateral testes, as metachronous torsion can occur, and I've seen 2 such cases over a period of 15 years. It's also important to bear in mind that occasionally a congenital testicular tumor may present in this way. Next slide, please. When you look at torsion of the appendix or appendage of the testes, this is more common in the prepubertal age group. Pain is the usual symptom, but compared to a torsion testes, it is less severe and more gradual in onset. I think Dhaval showed you a picture of a blue dot sign. I have to say, it is not very often we see this. Management is conservative if you're very confident of this diagnosis. And I would say that it's probably an experienced clinician who would make this diagnosis. If in any doubt, one should explore. Next slide, please. Epidermoonchitis does occur in the pediatric age group. When it is recurrent, it may be linked to underlying conditions like neuropathic bladders or ectopic ureters. I've also seen it present in boys who have had a 2-stage hypospadias repair and who present with strictures due to BXO many years down the line. In infants, vesiculatic reflux associated with UTIs can cause epididymoorchitis, and generally they present with systemic symptoms. However, it is very difficult to distinguish epididymoorchitis from torsion, and what is important to bear in mind, across all ages, testicular torsion is more common. Next slide, please. Now, this is something you may not see very often, idiopathic scrotal edema. As the name suggests, it is idiopathic. The scrotum presents with marked edema and is generally unilateral. Occasionally, it may be bilateral. And the swelling extends into the inguinal region or into the perineum. It's important to see that the pain is minimal or absent, and generally it resolves spontaneously. Next slide, please. There are other conditions which one need to consider. Sometimes an incarcerated hernia may present with, as was mentioned earlier, abdominal pain or discomfort and an inguinoscrotal swelling. Very rarely an acute hydrocele may present in this way, but it's rarely painful. Henoch-Schwann and purpura can present with acute scrotum, but generally this is bilateral, and you may see the purpuric rash across the body. Next slide, please. I would now like to discuss some work that was done by my colleagues here in Nottingham. So we looked at the orchidectomy rate for boys that were referred to us from our network, four district general hospitals, and those that presented to the A&E department at the Queen's. So what you can see from this slide is that the orchidectomy rate was about 50% for patients that were referred to us from our district general hospitals. Whereas at the same time, the orchidectomy rate for children that presented to our pediatric A&E was only 23%. Next slide, please. In 2016, the East Midlands Clinical Network, of which we are part of, looked at this and thought about devising some guidelines, and this took the form of a commissioning guide. And what was felt was that no patient should be referred from a secondary unit to a tertiary unit for torsion testes except in rare circumstances. And this was ratified by the Royal College of Surgeons and the British Association of Pediatric Urologists and the British Association of Pediatric Surgeons. Next slide, please. Now, this slide illustrates that over a 2-year period following implementation of the guidelines in our network, the orchidectomy rate in the district general hospitals dropped down to 21%, which matched the figures that were present at Queen's. Next slide, please. So in summary, I would say that torsion testes accounts for majority of the acute scrotum in postpubertal boys, and urgent exploration is mandatory. Surgery should be performed locally except in very, very rare circumstances when the boy may be transferred. And one should provide for training for adult surgical trainees. Next slide. And that, ladies and gentlemen, is a bright sunny day at Trent Bridge. A few years ago, this is clearly pre-COVID. Thank you.
Thank you very much, Manoj. That's great. So we're now at over 100 delegates watching, and I can say that passions are riding high on the question and answer bar, and we'll get to that in a bit as predicted. So this is good. This is why we're having this session. So last but definitely not least, we've had the urologists, we've had the pediatric urologists, but now we have the chair of the General Surgery SAC, a man who, prior to being the liaison member for East Midlands and getting all the questions and infighting about torsion management, looked slightly different to that, but here he is, Mr. Tim Cook. Over to you, Tim.
Thank you very much. Next slide, please. So I thought to myself, who should be managing suspected testicular torsion? And my first response was, next, shouldn't be me. But if it's not going to be me, next, please. Who should be doing it? Next slide, please. Well, who should be qualified to provide the service? So I went back and looked at not just the urology curriculum, but the pediatric curriculum and the general surgical curriculum. And all three curricula require competency in the management of the acute scrotum. So there's no excuse, doesn't matter what curriculum you followed, you need to be able to manage the acute scrotum. And not only that, all three curricula expect you to be able to fix a testicle. Might occur at different levels within the curriculum, early years in urology and the pediatric surgery curriculum, but by ST8 in the general surgical curriculum. Next slide, please. Why do we develop curricula? Well, there's really, curricula are developed and updated to allow the delivery of various service and manpower requirements, and ultimately we have exams to reflect the curriculum. Next, please. But it's really the service and manpower requirements that are the most important aspect of any part of a curriculum. So next slide, please. We've already heard from Manoj that transferring patients delays surgery, there's worse outcomes and increased orchidectomy rates. Next, please. Manoj has alluded to the study. But just to emphasize that the transfer of a boy with suspicion of torsion should only occur in exceptional circumstances. And there should be local clinical guidelines for the management and an agreed policy for treatment. Next slide, please. So what's needed? Well, it needs to be local provision, but training programs also need to produce trainees who are able to take up consultant posts and be able to deliver what is required in that locality. Ultimately, it's the trust that is responsible for providing a robust and safe service. And that might mean that there's ongoing training required and development following consultant appointment. Next, please. So why not me? Well, in Gloucestershire, we have 9 consultant urologists. We have two hospitals in Cheltenham and Gloucester. Acute scrotal conditions go through the ED department and the Pediatric department on the Gloucester site, and are seen by our general surgical registrars. But there's a standard operating procedure in post where if there's an issue, the pathway is that the general surgical registrars will discuss and be supervised by one of the urology consultants. So we do actually have urology consultants supervising our general surgical trainees and providing advice. But I think the message that needs to come across is there isn't a one-size-fits-all. So what's right for Gloucestershire isn't right for Nottingham or Liverpool or anything else. And there'll be some general surgeons in DGHs who will deliver that service. There are some large urology departments, such as Phil's identified in Liverpool, where it's the urologist. But there needs to be a robust system in place that ensures that these children obtain prompt surgical intervention to prevent unnecessary orchidectomies. Thank you.
Thank you very much, Mr. Cook. That's great and very balanced. Next slide, please. So on our panel this evening for questions, to add balance, because we felt it was a little bit urology heavy, we also have a general surgical trainee, our ST7 from East Midlands, Miss Preeta Dalia. Good evening, Preeta.
Hello. Some really interesting talks and an overview, but I have to sadly say probably the most training I've had.
That's a really good point.
So I'm quite an old trainee. I trained as a pre-registration house officer, and I did the traditional 6 months medicine, 6 months surgery, and part of my 6 months surgery I did 3 months as a urology PRHO or FY1 equivalent, where you did quite a lot as a house officer in those days. And that was a point that I learned to examine and I guess diagnose torsions and my differentials. And I think it's the differentials bit, which I appreciate aren't as important as a torsion, that we don't get, I feel, as much experience and feel of, particularly in adult patients. And what I'm seeing more frequently, as I said, I was trained a fair while ago in terms of managing torsions and exploring testicles, and I do it the traditional way for the midline. Rafi was through an old school staff grade, and I think the only other look-see I've had from a senior point of view is probably a pediatric consultant when I was up in Aberdeen. But prior to that, and I think during I was trying to think back over the last couple of days, I don't think I've had much consultant involvement in my training personally for exploring scrotums. And from my point of view, although my training has given me, I'm quite proud and quite glad that I've had that wealth of experience from the input I've had. I just worry now, because what I'm seeing more and more is my juniors that I'm trying to support, my SHOs, my ST3s, my ST4s, And I'm thinking ahead in terms of I'll be a consultant soon. It's me training them. And speaking to them, they are quite anxious and quite worried about it, because what we don't always appreciate is what the long-term effects are. So when I do operations on patients that I can do at my level as a registrar, if I'm unsure for my diagnosis, I have a consultant that I know will be over my shoulder to have a look. And I don't think we always have that with emergencies for scrotal conditions in every site that we work. The other thing is also our operating. If I need a head through the door to have a look, we have that option. And I have sometimes felt I did not have that option where I would have liked. And so you feel that you're in a situation where you're delivering substandard care. This is my personal opinion, and having spoken to some other registrars. And that leaves me out a little bit on the limb, whereas a registrar and a SHO, I'd be happy to do what boss says, but thinking ahead in terms of consultant, and certainly one of the questions that's been raised, what is the litigation side of this? And I don't follow these patients up. And as a surgeon, I quite like to follow patients up because I want to see what the after effects of my surgery is. And we don't have that luxury either. So although these patients do get follow-up, having had a orchidopexy, we don't see them. So we don't have any general feedback unless there is direct feedback from me as a surgeon. And that leaves me a little bit worried.
That's excellent. That's predictably articulate. Thank you very much, Preeta. So next slide, please. We're now on to the discussion. We're going to relaunch our poll live now. So on your screen, you will get a box to vote again on the same 2 questions to see if our panelists have changed your mind. And if you want to make the box go away to take part in the discussion, you have to vote. Oh, okay. No, just for the panel, hosts and panelists can't vote. You have to press on the red dot in the corner. Right. So we've got a lot of really interesting questions here. So there are some people who have come late to some of the presentations who are asking things that were covered. And then there's some more controversial ones. And there's clearly a lot of established trainers from either specialty writing in as anonymous attendee. So just to Susie, because it was from your quote, just to go over your technical details again, we have from Sami Mohammed, who I think must have come in a little later, absorbable or non-absorbable sutures to fix it.
Non-absorbable sutures to fix it, which is also useful because the patient's going to be able to feel those for a small amount for the rest of their life. So if you're not sure if someone in the past has had it fixed, then you'll be able to feel the sutures, but non-absorbable. The rest of the operation is absorbable, so closing or vicral, but something like a Prolene to fix with.
And what size, Susie?
3.0 Prolene, probably, or 4.0, maybe smaller. Yeah.
Okay, that's great. Then we have one of our slightly controversial ones, and I might put this to Manoj, our pediatric representative, and it says, it's quite frank English, I have never worked in a hospital, small or large, where urology do, well, this is kind of, yeah, do pediatric torsions, even when trainees and consultant urologists are on call in their hospital. So how do they gain the necessary experience to get a level 4 PBA in pediatric torsion?
So the guidelines state that anybody over 5 years of age, probably Tim will support me on this, should be explored locally. There's no reason to transfer a child above 5 years of age. So clearly, as we have shown in our network, that's what happens and that's what should be done. Now, of course, the numbers for trainees going through rotations and seeing the number of cases may not be sufficient, but it's a very simple, straightforward procedure. And what I don't understand is, sorry to be controversial, when people can do laparoscopic colectomies and things, this is an operation which is fairly box standard. You have to put 3 stitches, explore. I think the GMC will not support you if you don't explore a scrotum and say that you can't do this. I'm sure the other panelists would agree with that.
So let's go to Phil and just say to Phil, so everybody's now asking loads of questions. How do they get a level 4 in a pediatric torsion then for CCT?
So you would normally expect, so these are teenagers largely. So largely the reason that you get a torsion is that the weight of the testicle changes with puberty and your bell hanger is no longer effective. And so mainly...
That's a phrase I'm just going to have to memorize forever now.
but it's true. So they just get heavier and hang. And so now they're heavier and hang. And on that basis, that's what causes it. These boys are not, it's not taking 3-month-old babies to theatre and operating on them. I know I shouldn't tell a paediatric surgeon this, but these really are small adults. They're not in the paediatric surgery. They might have some support needs, which the paediatric nurses will be happy to support on the ward, but they are not. This really just is an adult operation on a, well, often a fairly adult-sized child most of the time, because 13 or 14-year-olds, they'll be 5'6". They're not some little baby that we're asking you to operate on. It's not like that. So we normally would see them, and they will get experience like that.
So we'll go to our general surgery SAC chair, and we've got a question from Lizzie Elsie, and I would agree with exactly, I was going to make this point. So we all agree it is a simple procedure, but they aren't trained to do it in general surgery. So those days of a general surgical consultant who had a groinology kind of list on a Friday afternoon within his job plan has gone. People don't have that kind of exposure in their routine day to day, and then they're faced with this. And it isn't a lap colectomy, but lap colectomy is something they see day in, day out. This is a terrifying, novel situation, even though it is simple. So how is our general surgery SAC, how can we make our trainees more familiar with this, train them in it, make them feel confident? How's that going to be?
Well, they're not going to see emergencies on their day-to-day elective basis, whether they're in urology or
scrotal exploration. They could see scrotal exploration.
So what they need is exposure to it throughout their training. There'll be some hospitals where it is taken on by the urologists, but there are plenty of hospitals around the country where it is taken on by the general surgical team. I've given you the example in Gloucestershire where the general surgical trainees do get exposed to it, but they're supported by the urology consultants. Ultimately, as I've pointed out, it's down to the trust to decide how they are going to deliver that service. They shouldn't be sending them elsewhere. So if a new consultant turns up and doesn't feel confident or competent, there needs to be a system of training in place locally to ensure that that service can continue to be delivered in that given trust.
So I'll just interrupt you there, Tim. The difficulty isn't what you're saying. So I appreciate what you're saying. So the new consultant is a general consultant who's covering peds usually and doing pediatric torsions with some extra training post-appointment. But the political difficulty with all of these arrangements is you have a general surgical SPR covering an adult torsion, operating on adult torsion, and their general surgical consultant boss is not willing to supervise them or doesn't feel, because it's not part of what they do. And it's the urology consultant who may be based somewhere else, and they find themselves in this very difficult triangle of who to call. And it's not really what to do. It's, is it viable or isn't it viable? And I don't know, and I don't want to call, and I don't even know who to call.
But I would suggest to you that that is a fault of the local arrangement. So that's falling down at that point. So for the general surgery registrar to not know who to call means that there isn't a robust system in place in that organisation. And therefore, you need to escalate that up to the chief executive, is ultimately responsible for the safety of patients within that trust.
And in the abstract, who should it be?
Who should be doing it?
Who should be supervising the general surgical trainee dealing with? It's usually in the site.
As I said, Jill, I don't think there is a one size fits all. So there will be some. Phil's talked about sort of five-day urology services where the service will be different during the week compared with the weekend. There are some hospitals where it's all done by the general surgeons. There are other hospitals where it's all done by the urologists. So you can't say who should do it there and who should do it here. It is very much down to a local provision. I don't know if Phil has a comment on that.
So I would, for example, I'm looking at a urology service as an external review at the moment, and there are 90 minutes between the two A&Es. The fastest you can go on Google Maps, even out of hours, is 90 minutes drive. It isn't reasonable, from everything we've heard, to put somebody in an ambulance and transport them for 90 minutes so that there is somebody on site. You have to have provision at the local A&E, and it's difficult to close an A&E when it's as isolated as that. So at this point, you've got no option, but you must ensure that they are trained. Now, you can train people to open up scrotums, which is really all we're talking about, because we know that even if you do occasionally take out a testicle that might have been saved, you'll lose many more testicles by putting them in the ambulance and sending them to someone else to do, because the time is more important than the decision, and you will get the decision right most of the time. When you looked at that data that was produced earlier, in fact, the orchidectomy rate was just as good in secondary care as it was shipping it. So I think that's where we're up to.
So I think that's a really reassuring statement, especially for the trainees who are calling in at the moment, that you would not be criticised for exploring. So the right decision is always take it to theatre and have a look. You're on mute, Phil. That is another £10.
Well, you're absolutely true. So you'll never be criticised for taking them to theatre. You could always run a risk of being criticised if you don't take them to theatre. I can confess that I was once sued for missing a torsion. And the reason was that they'd already had an orchidopexy in the past. And this guy went on and on and on about his orchidopexy. He was in his 40s. I said, well, it's been fixed once. It ought to be okay. He'd had a undescended testicle brought down as a child, and it clearly wasn't fixed, and it came back dead afterwards. It isn't impossible to miss it, and you are still better always to explore.
So take it to theatre. Okay, so that's really useful. Right, a question for Daval. This is from, gosh, this is a difficult surname. So it's from Niall. How would you manage a 20-year-old man with a recurrent testicular pain and the testis isn't tender, no evidence of an appendage torsion or epididymal orchitis or any other condition, but acutely presenting?
Well, this sounds like intermittent torsion to me, and if the testicle is not tender at that point, then I don't think there's any indication to take it to theatre there and then. However, if you do think it's intermittent torsion, it's something that may need to be fixed electively, and that's something that would be referred to a general urologist or a urologist at some point down the line. And there will be a urologist on call, be it a registrar or a consultant at your hospital or your adjoining hospital, that will be able to give you advice. But
okay, thanks for that. Another one for urology, maybe Susie, because I like where this is going. So this is from Obefemi Wuraloa, who says, when exploring the hemiscrotum with an actual torsion, do you always have to have closed the hemiscrotum you're on before opening the contralateral side?
There wouldn't be one set answer to this, and people would do different things, but no, I wouldn't. I wouldn't close the dartos on one side and then go to the other side. But it depends. If you're going through a midline raphe incision, then you'd do one side, probably fix one side, not close the dartos, and then go through to the midline raphe to the other side, the midline dartos to the other side.
Okay, Deval wants to leap in here.
Well, what I was going to say, I'm a bit of an impatient surgeon, so I don't like waiting for 5 minutes. So while I've wrapped the testicle in gauze, I'm fixing the other side anyway, and that gives me the 5 or 10 minutes to come back and have a look. So yeah, you're absolutely fine to fix another side while one side is open.
Okay, and we've also had this asked by a few people, and I know Susie's answered it already informally. So Susie described the midline raphe incision. I've got stories from trainees who said they've done that in front of pediatric surgeons, especially who've held their hands and want to do a tiny little transverse thing in both sides. So Deval, grown-up urology, what's your approach?
I do a bilateral scrotal incision, to be fair.
So two transverses.
Two transverse incisions.
Phil?
So I'd still use a median raphe if I'm going to do it. The length of the incision will be about the same either way when you added it together. And the thing about scrotums, particularly adult scrotums, heal very well. It's quite easy to hide a scar in a scrotum.
I'm going to have to compile a Professor Cornford list of sayings at the end of this webinar. It'll be great. Mr. Cook, what sort of incision would you make when faced with a torsion, should that occur?
Well, as I've already pointed out, I don't do them. But when I did do them as a trainee, I used to make a median raphe incision.
Excellent, very good. Okay, so then we have, well, it's all about logistics here. So yes, we have Mr. Welsh, President-elect of the ASGBI, says general surgery always have to do whatever when no other surgery is available. That is why it is general. There we go. It's more of a statement than a question, I think, probably on the question bar. So a question from Anwar Ahmad, probably to Manoj, is who should deal with patients who are under 5, urologists or general surgeons, patients with torsion?
So in our network, we suggest that those patients may have other issues, and we'd be happy to accept them. That's what we would say. If there's a surgeon locally who's competent and is comfortable, then they can deal with that. And it's always useful, as was said earlier, to liaise with the tertiary unit and speak to the team there first.
So those ones you would want transferring?
Yeah, we have said that under 5. So that's what we have said in our document. So if it's somebody, say an infant, we wouldn't want somebody with little experience to expose such a child.
What about 4 years and 10 months?
Well, come on. As was said earlier, some of these children are about 50 kilograms at that age sometimes. So in that setting, if the local team is happy, we wouldn't be annoyed with them.
I guess it's anesthetics as much as surgery, isn't it, sometimes? So I suppose that's the point. We have good evening, Professor Moog from Locked in Glasgow. Have there not been any surgical or medical advances in conserving testicles rather than, you see, that's a very feminist approach. I like that. Conserving testicles rather than removing them. Any research? Professor Cornford, that sounds like an academic question.
Yeah, but not really my area of academic expertise. But but the short answer is no, because once you've cut the blood supply off, you've cut the blood supply off, and the problem is it's dead. And after 24 hours, it's quite likely to be dead.
So we take it out.
There's still no blood supply.
One for Daval, and this is, I was going to ask this as well, Katie Cross. Any truth about that thing about antibodies? If you leave the testicle in and it's not quite right, then it's a sanctuary site or something, isn't it?
Well, there's a bit of debate as to why patients who either lose their testicles or you explore them have increased risk of infertility. One is thought to be antibodies, but the other one is just breaching the blood testis barrier. So there is some evidence that it could be antibodies. Leaving a testicle in that's dead, you would remove it at some point down the line, but I think they're going to have a reduced risk of reduced fertility at that point anyway.
Okay. Now, oh dear. So, and again, a similar sort of vein, and we might ask, so we'll ask our general surgical registrar this question to sort of prove the point. So this is from Robin Williamson. What are the pros and cons of leaving a doubtfully viable testis in somebody? What would you do then, Preeta, if you put the swabs round and it sort of wasn't blue anymore, they didn't look like my necklace? So what are you going to do then?
So I've been taught just gentle stab, open, see if it bleeds, just to be doubly sure. If there's any debate whether it's viable or not, leave it in place is what I've been told. And then I would absolutely 100% sure make sure that my friendly urology colleagues will follow this chap up. That's what I've been taught to do. If it doesn't pink up, if it doesn't pink up, and I'm 100% sure that is dead. In my entire training, I've done 3 orchidectomies, 3 or 4 orchidectomies. And in terms of doing the actual orchidectomy, it's much like I feel the actual exploration. It's not a technical challenge. If you've seen it done, you've done the numbers. It's the counselling part afterwards and making sure that the patient has appropriate follow-up.
Yep. Okay. So again, we're getting a lot of discomfort around the medico-legal side of things, which is completely understandable. So maybe to, I think, poor old Phil again, or Phil and Tim really. So surely general surgery trainees should be signed off for a procedure before they're doing it on their own, unsupervised, and that involves the diagnosis and the technical exploration. So shouldn't they be supervised by either a visiting consultant urologist? How do we get them signed off as competent to then do this thing? Phil first.
It will depend very much on how it is locally set up, won't it? But so locally on Merseyside, the answer is that they're all done by urologists. It's a fairly densely populated region, and as a consequence, we don't have a problem like that. if you are in a more rural community where there isn't a urologist for a long period of time, then it will be done by whoever is there.
So Nottingham's a bit more rural than Liverpool. So so they would have a general surgical registrar who isn't signed off on them taking them to theatre.
Yeah, in Nottingham, we do have positive. The general surgical registrar's not happy to do the procedure. Either urology registrar or urology consultant will come across, but we're obviously at a different site, so there is a time delay there.
The reality, Jill, is that no trainee should be going to theatre to do a procedure. It doesn't matter whether it's a torsion or anything else, if they're not competent to do it. So we had an example recently where a new ST3 had someone with a torsion, phoned someone else up from the urology department and said, you should be able to do it, it's in your curriculum. He said, yeah, it is in my curriculum, but I've never done it before and someone needs to show me. I'm very happy to do it. And that's essentially what needs to happen. So I'll go back and say again, local arrangements need to be in place to ensure that there is adequate supervision in whatever specialty. No trainee should be doing something that they are not competent to perform.
So should we preempt this then and put some sort of structured elective exposure to the approach and the organs in question, C necklace, before they are faced with a situation in the dead of night?
Well, is that any different from saying appendicitis? You don't see you don't come across appendixes on an elective basis. Your exposure is through the emergency take, and you are adequately supervised to start off with, and then you gradually increase those competencies and act independently.
So is the theme,
so the training program needs to be able to provide the exposure and experience for both urology and general surgical trainees to gain adequate experience by the time they complete their training.
So with the appendix analogy, when they get stuck, they will call the consultant. And with the torsion analogy, in the different centre, with the, and I totally appreciate the
I disagree.
urology rotation.
You see, I think the local organisation, the local trust or health board, should have a system in place that is robust to provide direct supervision for the trainee operating. They shouldn't be left to be acting independently with someone who is more than 30 minutes away. So that is a problem for the local trust to sort out.
I can see lots of local chief execs getting emails tomorrow. So a very pertinent question here from Paolo Sorelli, and it's to the urologist. So we'll go to Manoj, it's particularly you. Would the urologists on the panel be happy for their 5-year-old son to have a scrotal exploration by a general surgeon who's only performed 2 in the previous 5 years?
Simple answer, yes.
Really?
Well, look, if you're living 50, 70 miles away from the nearest pediatric hospital and it takes you 2.5, 3 hours to get to an A&E, simple answer is yes, because it's time critical. You lose the testes.
Okay, so you want someone to look more than no one.
Yeah.
Okay, so if when you get to A&E, there's a consultant urologist, a consultant pediatric urologist, and a consultant general surgeon, which one do you want to look then?
I'm a pediatric urologist, of course, a pediatric urologist. Goes without saying.
Okay.
But it's just not true. Everyone worries about the 5-year-old, but the 5-year-old is not where the problem is. This is not a condition of 5-year-olds. And the chances are that if you're a preschooler, you've got some other issue that is the cause of the testicular pain. The problem is a whole load of 13, 14, 15-year-olds who are as likely to turn up pissed as they are to turn up with this. And this isn't pediatrics in the way that you think about small blonde children running around, okay? This is pediatrics as in the real world in central Liverpool.
So then that's I understand what you're saying, conflicts with the other statement of just explore, you'll never be told off for exploring. So we're still going to take the small blonde 5-year-old and I'm going to remember what you said and I'm going to explore the testicle because I don't know the other differentials because I'm a general surgeon. Manoj?
Yeah, Jill, so look, in my presentation, I showed clearly in the prepubertal age range, the commonest thing that you see is probably a torsion of an appendix testes or hydatid of Morgagni. But, and in that situation, you can afford, if the child generally presents later, about 24, 48, sometimes 72 hours down the line. So as Phil said just now, the pathology is slightly different in that age group. Most of the time when you get acute torsion, it's in the older teenage boys.
So that's helpful as well. And all this is why we're having this webinar, and all the general surgical trainees certainly and consultants are listening and learning, which is really good. But what about the difficult situation where it's a short history, it's under 6 hours, he's a big 5 and his testicle hurts? We should still explore them.
I would.
And
I would too.
Okay.
Yeah, I think with all of these things, George, you've got to err on the side of caution.
So go to theatre.
I agree with Phil. You're almost never going to be criticised for exploring a testicle, but you could always be criticised for not exploring one. And many, many years ago, when I was a general surgical SHO, I remember my consultant saying, when you're doing appendectomy, you'll come across many normal appendices, and if you don't, you're not exploring enough. And that's the same with torsions. If every torsion you do is a necrotic testicle, you're not exploring enough, in my personal opinion.
Agree, except we're just about to change that and say you should probably CT appendixes now and not have that huge negative appendicectomy rate anymore. But so we've got Anne Stebbing, a name we all know, who says that an ST3 would need supervising for most of their emergency procedures for that whole year anyway, which is a very valid point. We now have a question. Who should we put this to? I think this is Manoj again. Statistically, there is a trial of salvage of torted undescended testes. Is that of any significance?
So majority of the time, this will present in the infant age group. I've certainly come across 4 or 5 in the last 15 years. I have to say that they generally present very quickly. And generally what we find is, rather than doing an orchidectomy, you may be able to salvage the testes. But again, it depends on who sees the patient first. So if you have an astute GP or a district general hospital seeing the child and referring the child early, then yes, the prospect of salvage is pretty high.
Okay, that's just good to know. And now this is a test case, so Preeti, you're the general surgical guinea pig registrar on the panel. When consenting for exploration, and obviously you consent and you mentioned possible orchidectomy, what do you tell patients about the impact this will have on their fertility?
What I've been taught and trained is actually leaving a torted test. So if it's torted, you've got a chance of having torsion on the other side, and therefore it's more important to actually have a look, and that is more impactful on their fertility. In terms of leaving a testicle that is questionable viability, my understanding is that the newer roles that we've been told is actually, if there's debate about viability, to leave it. If you think it's not viable, to remove it.
So I think the question, which is from Abigail Nelson, is what do you tell you? So you tell the patient you may have to take their testicle off if it's torted and dead, and what impact will the removal of that testicle have on their fertility? I'm not expecting you to know the answer to this.
So I tell them they've got one other testicle. It's more important to explore. If it's torted, then the other one needs fixed as a definite.
Don't waffle. What does it do? You're taking off their testicle. I was about to say a rude word then. What's it going to do to their fertility?
So they should still be able to have children. In terms of how much their fertility is impacted, I would say that they will have some impact on their fertility because they've now only got one testicle.
Well,
we're only going to take this off because it's dead.
Yeah.
Okay. So it isn't going to make any difference to their future fertility because it's already dead. That's the point. And if you delay it, if you put them in an ambulance and you send them down the road, it's more likely it will be dead. So there is no benefit of telling them. So what's the other option? Because you have to explain to patients what the alternative is to taking this testicle off. So you've got a dead testicle in there, okay, and it definitely is dead, and I'm going to take it off if it's dead. And if I don't take it off, well, you'll probably get an abscess, and it will then fungate out through the tumour and discharge. It will still be dead, and it still won't make any difference to your fertility. It's still dead.
All comers taking off a testicle, what does that do to your fertility?
It can affect your fertility. So, I do consent that it could affect your fertility further down the line.
But that fertility is already affected because
Correct.
that testicle is already dead. And so the only question is there something you could do to reverse it? So losing a testicle might affect your fertility down the line, but this testicle is dead.
So my inexperience as a general surgical registrar means I will take off one that isn't dead.
No, not as likely.
No.
So the evidence suggests that your inexperience as a general surgical registrar means you'll put them in an ambulance and send them, and it's much more likely to die on the way than it is to die with you taking it off.
So the safer thing, though, as you've said again, and this would be the reason, is that we leave it in. If we think it's viable, we leave it in. We don't take it off. Okay, that's useful. One is Preeta.
Sorry. So the issues, I think, or when you have difficult cases, and the two difficult cases that always spring to my mind was I had a retorsion. Someone had already been fixed, and it found basically they hadn't got down to the testicle; they'd fixed the wrong layer.
Oh,
so
dear.
Next one. So again, history and clinical examination. I said this is definitely torsion from my point of view. The only thing that throws me is I've had it fixed, discussed it, explored it, was correct. But then my worry is, and I don't know who fixed it the first time. That could have been one of my peers. That means they didn't fix it correctly.
Okay, we're going to have to go really quickly because we're nearly up to time. We've got a bazillion more questions. So we might ask subsequently if ASGBI Secretariat can arrange for the panel to type some of the responses, because people do want typed responses to their questions and they're very good. Susie, regarding orchidectomy, do you offer any psychological support after that post-op?
Don't routinely offer any, no. You don't have much time before the operation to talk to the patient about it. They're often in a state of shock, so you do need to spend a bit of time with them afterwards on your ward round. So the surgeon, myself, would go and speak to them, but I don't routinely offer them.
Okay, there's a caller here who says if the findings on table are equivocal, then urology consultant should be consulted for advice. But that's a difficult discussion to have over a phone, isn't it? What are there any particular things you would want to know, Daval, over the phone, if somebody's calling you from theatre unsure? Anything useful they could tell you?
Oh, there's Preeta said I'll make an incision in the tunic, and if it bleeds, that gives you some idea.
So that's an extra thing to do that they might not do as standard.
That's an extra thing you could do. But secondly, err on the side of caution. If it's black, take it out, and if it's dusky, keep it in.
Okay, and everybody is saying the technical bit's not so hard, it's the diagnosis that is difficult. So we're saying take it, and if in doubt at all, take the patient to theatre. That's the thing we won't be criticised for. And when, quick one for Manoj, perhaps, when to do a dartos pouch?
Well, to be fair, when you are doing a torsion test, the layers are so sort of disorganized and inflamed, it's very difficult to make a dartos pouch, in my experience, I would say. But it's easier to make a dartos pouch when you're doing an orchidopexy for an undescended testes rather than for a torsion testes.
Okay, and one to Daval, would you ever put in a prosthetic testicle acutely?
I don't tend to put them in acutely, no, because you're worried about potential infection there and things like that. So generally, they need to be counselled, and as Susie said, there's not a lot of time beforehand, so normally it's afterwards. Okay, there's Robin Williamson, who might be a urologist, I'm feeling, did some work in Bristol and found that post-unilateral torsion, there might be this thing again, which Katie Cross brought up, autoimmunization by the damaged testis. And so they did a trial where they biopsied the normal one at the time of the contralateral fixation and found abnormal spermatogenesis, because it's often an abnormal testis that undergoes torsion. This person must be a big cheese in your world, Professor Robin Williamson.
It's certainly true that you're more likely to have a torsion if you've got an abnormal testicle. That is true. There's definitely a link.
Okay, another question about prosthesis and post-orchidectomy. Would you counsel all patients prior to exploration if they would wish to have a prosthesis or not? Phil?
No.
No, it's a hot situation.
It's not going to happen as a hot thing. It's going to happen as a second procedure. Of course, it might happen after the event if you had to do an orchidectomy and they go and you'd say, yeah, someone will talk to you about a prosthesis, but they're normally too shocked at this point to take it all in. How would you like to discuss the silicone migration, whether that's going to be an issue? You can't take that in just immediately afterwards.
Fair enough. One for Daval, again, it's the same thing, is should we explore patients with a 48-hour history of pain, but just not looking like a typical torsion? That sounds like that intermittent non-tender testicle, but something's happening patient.
Yeah, and they're the kind of people that you potentially could get an ultrasound scan on to see whether you need to take the testicle off there. And then because a few hours here or there when it's 48 hours down the line is not critical. The critical period is you don't want to go for 6 or 12 hours. And, you know, most of the institutions we work in, to get an ultrasound or a Doppler at, you know, in the middle of the night is nigh impossible.
Okay, I think we've tried to address nearly all the questions and we're running out of time. We mustn't run over. So the poll that we have had this evening, who should manage testicular torsion in children, is now 25% general surgery, 46% pediatric surgery and 29% urology. So a fairly even split really. And who should manage testicular torsion in adults? General surgery, 27%, urology, 73% are still very keen. And I think in a situation like Liverpool and a setup like that, it probably is the right thing, isn't it? And totally accept different places. And it's all about, I think what we've learned this evening is time is critical. Don't fanny around at the beginning. You wouldn't be criticized for opening a testicle to look and fixate. Susie's given us a lovely how to do it, and that will be open access up on the ASGBI website afterwards for general surgery urologists to consult in the dead of night in the operating theatre. So it leaves only time for me to thank our secretariat hiding behind the screen, Bav and Vicky, for facilitating this evening's performance. I'd like to thank our speakers for giving so generously of their time and expertise and teaching us all some stuff. I think it shows we're all as ever striving to get it right for our patients. And this last slide, which I can't see on my screen, is promoting our next educational webinar, which is going to be similar pills in the bile duct rather than in the scrotum. Okay, thank you very much and good evening, everybody.
Thank you.
Thank you.